Hey, good morning.
Okay, you're recording.
Thank you. We're going to re-record the first
Hi, this is
half,
Ronnie.
respiratory
Great. How
disorders
are you?
review. And so we'll go ahead and get started. This is on chapter 32. So when you look at common respiratory disorders, what conditions most often contribute to the overprescribing of antibiotics? Usually those are viral upper respiratory infections or pharyngitis, sore throats that are hard to discern if they're viral or bacterial, ear infections, and the common cold. Sinus infections contribute to the overprescribing of antibiotics. What do parents do whenever their children have upper respiratory symptoms that is dangerous? Well, one of the things they do is they give over-the-counter cold and cough medications, which is usually given with their thoughts about adult doses, because they weigh 150 pounds and their child weighs 50 pounds. Then they'll give a third of an adult dose, which may or may not be appropriate. So children have died from overdoses of over-the-counter cold and cough medicine. How much should you tell the emergency room if you're referring a child there? You will want them to have the baseline information that you've gathered so that they can pick up right where you left off whenever they go into the emergency room. Which of these children were treated for a sinus infection but inappropriately, and why? An infant with maxillary and ethmoid sinus infection, a toddler for a frontal sinus infection, or a school-age child for a frontal sinus infection. Well, the maxillary and ethmoid sinuses develop as early as late infancy, the sphenoid at 3 to 4 years of age, and the frontal sinuses around 6 to 10. So the toddler that was treated for a frontal sinus infection, that was a little bit early because the frontal sinuses don't develop until school age. Doing CPR on infants, what's unique about them? And if you remember back to your CPR class, you probably remember that if you hyperextend their neck, it can constrict the airway. Their trachea and airways are much more compliant than adults and therefore more vulnerable if they have sustained intense effort. So their muscles cannot handle continually being in stress with respiratory illnesses. So there's a possibility there of airway collapse. The ribs on this baby are more horizontal than in the adult, and that limits the baby's ability to expand their chest as well. What is the main muscle that should be of respiration? That would be your diaphragm. You're seeing that in green, of course, and it can be helped by the intercostal sternocleidomastoid, spinal, neck, and abdominal muscles. Normal exhalation occurs as a result of elastic recoil of the lungs. Based on anatomy, where would you expect that a foreign body would be found if a peanut was aspirated? As you look at this drawing, you can see that the right main stem bronchus is shorter and wider than the left bronchus, so it would be found lodged there. So those would be the places you would hear a snap or a clap, or you might hear breath sounds in that area. In preemies, what is missing that reduces surface tension and prevents the airway collapse? As you can see, with surfactants, there's more moisture, and therefore the lungs operate much more efficiently. Without it, there's greater surface tension, and so that surfactant has to be replaced, oftentimes in prematures. Answer the following question. What age group has the highest airway resistance? That would be newborns and young children have the highest airway causes airway disease. These are the usual causes for airway disease. Presence of an intraluminal material, that would be like tumors, secretions, foreign matter. Neural thickening would be like edema of the glands or the mucosa. Number 3, contraction of the small muscle would be like that found in croup. Number 4, extrinsic compression would be like if your abdomen was distended, or if you have a condition called pectus excavatum, in which the sternum is depressed in your chest. And I'm sure you can probably think of some other examples as well. Sounds of distress, where are they coming from? The barking cough is probably coming from your voice box or larynx. Stridor is usually above bifurcation of the trachea. Wheezing is usually due to a narrowed lumen, and that can be inspiratory or expiratory. In the absence of breath sounds, you may have a lobar atelectasis. Crackle can be a primary clinical manifestation of lower respiratory airway obstruction that usually occurs with expiration, but can be found as well on, for the most part, on mid to late inspiration. Grunting is always a bad sound to hear. What happens when you cannot get air out, as in cystic fibrosis and emphysema? Well, what happens to the child's chest is it gets to be a barrel chest, so that percussing the chest would be hyperresonant. Symptoms worsen as the obstruction increases. The body uses accessory muscles. Dyspnea results. Serious if below 85% oxygen concentration. Mild obstruction reduces the respiratory rate and increases the tidal volume, whereas severe obstruction increases the respiratory rate and the amount of retraction. What causes restricted disease? We've already mentioned things like pectus excavatum, and this is a picture of a child with it, but not as good as I'd hoped, where the sternum is depressed. We talked about abdominal distension can cause that. Some children are born with Wernicke-Hoffmann's disease, where their neuromuscular system is weak. Lobar pneumonia could cause this problem. Pleural masses could cause it. So in this child, the caving in of the sternum can compromise both the respiratory function and the cardiovascular function, leading to cardiac dysrhythmias due to the lower oxygen supply to the heart. If it were bowing out, as in emphysema, it would be called pectus carinatum. But in all these cases with restrictive airway disease, you have exercise intolerance. The children get fatigued quickly. There's wheezing, their chest feels tight, they have chest pain, palpitations, or dizziness. And usually, if it's that severe, they're going to need a surgical repair being done. And your book talks about the ravage and the noose procedure that's usually done at the start of puberty. Which children need further workup? For severe infections, they do give you criteria for that in your book. 4 or more ear infections in a year, 2 or more serious sinus infections, 2 or more pneumonias in a year, persistent oral candidiasis, failure to thrive, 2 or more deep-seated skin infections, 2 or more months on antibiotics without improvement, and the need for intravenous antibiotics to clear infections would warrant researching immunodeficiencies. I talked to a faculty member this week whose child had had 2 ear infections, and they had mentioned that they were going to test them for immunodeficiency. So I reminded her it'd probably be good to look at the guidelines, and as you can see, that is not going to be appropriate at this particular moment. So it upset the mother for really no good reason. But that could be a problem if there's family history of immunodeficiency diseases. So which ones need further workup? The severe infections, the persistent infections with poor recovery, the infections that are unusual organisms, and then the infections that keep reoccurring. I'm sure that you at some point in your education have been taught the PQRST method for trying to figure out what's wrong with children, and you certainly would use that method with the respiratory infections. So you would look for what's promoting, preventing, precipitating, and palliating the problem, what's the quality or quantity of the illness, the region, the radiation of the symptoms, the severity, setting, simultaneous symptoms or similar illnesses in the past, and then the temporal factors when the time. So if you study Table 32.1, where the key characteristics of cough, common causes, and questions to ask in a pediatric history, there's much more information there as well. So on the physical exam, starting with the vital signs. Elevated respiratory rate is a key indicator for lower respiratory involvement. When you're looking at the nose, you're looking for rhinorrhea, polyps, bleeding, the septal position, the color of the mucous membranes. Are they red, beefy red like you'd see in sinusitis, or are they boggy like you would see with allergies? Looking for foreign bodies. And on the first page, I mentioned that my daughter had a unilateral nasal drainage for several months before I could convince the third doctor I took her to that she actually had a foreign body up in her nose. By then it was pretty well enlarged in there and had to be dislodged with a lot of blood and stuff as a result. So she stuck a foam up in her nose from the daycare center. So any unilateral smelly drainage like that, you need to think about that, especially in younger children, that they put something up their nose. When I worked in the ER for a while, we had a kid that came twice in the same night for putting a pee up his nose. So they're notorious for that. So you need to look for erosion, looking in the throat for lesions like you might see with hand, foot, and mouth disease, vesicles, exudate like you would see with candidiasis, diphtheria, enlargement of structures, and if the epiglottis is a consideration, then you certainly wouldn't want to examine that throat and elicit a gag reflex. Look at the chest, the depth, ease of breathing, are the lungs, both of them rising and falling symmetrically, and what's the rhythm of the respiration? Are they using their abdominal muscles and the seesaw patching in order to breathe? Do they have retractions? And those could be intercostal, diaphragmatic, the neck could be used to help pull, to help breathe. Then you need to look at prolonged expiratory phase is really characteristic of lower respiratory problems. And then you can check the chest by percussing for hyperresonance or dullness that you might hear over pneumonia. And when you're auscultating the chest, the upper tract, you probably will hear snoring, stridor, musical or wheezing tracheal sounds, and that can be a source of referred breath sounds. So when you're listening to the chest, you might think the chest sounds awful in a little kid because of the small size of the child. but it just may be with throat sounds from up here in the head. Lower tract respiratory problems usually you'll hear crackles, bronchi, pleural friction rubs, wheezing, and bronchial breath sounds. So just be aware that what you're hearing can help you determine where the problem is coming from. One thing that none of us, I guess, at the moment, unless you're in Colorado or in the Alps, have is mountain sickness, but your book does mention it. And I live, as most of you know, in two places. So in Little City, it's 500 feet above sea level, and where I live in Johnson City, it's 1,500 feet above sea level. And I can tell you that I'm more short of breath up here. I can really tell the difference when I change from one place to another. But with mountain sickness, where you have really thin air, as my grandfather used to say, who lived near the Alps, you can have headaches, insomnia, irritability, breathlessness, and nausea and vomiting. I try to only have the breathlessness part for my family's sake. Diagnostic studies that you would use in primary care. Your book mentions many, but most of those are used in the hospital. So we're not going to talk about those since you won't be doing those. So pulse oximetry is really helpful in primary care. If you did a CBC, if their oxygen level was low, you might see a rise in red blood cells because the body's just trying to produce more red blood cells to carry more oxygen to the body, which of course doesn't help. Then blood gas studies, a rise in PaCO2 is an ominous sign for children, but again, you may or may not have that capability to do that. So you may not want to do that because it can be painful. MRI, CT, if you're ordering a chest x-ray, always order an A, T, and lateral both. And then pulmonary function tests, you have to be certified to do these, but most primary care facilities have that as a possibility. Sweat testing if you think they have cystic fibrosis. Cultures if you think they have TB or some weird organism. And then, of course, blood work to rule in or rule out bacterial versus viral. And then, like I said, most other testing would be done by specialists. So some general measures with these children is, of course, to avoid smoke, which hopefully you can convince the parents to do some smoking cessation classes. Good hand washing, because you can spread it. Some of this stuff lives for up to 30 minutes on the spot, so you actually can spread it. And then immunization coverage to make sure they have their immunizations. And I was reading something on the internet yesterday, which is kind of a side topic, but nonetheless, the Amish, much as they're into living very plain and simple lives, make sure that their children are taken care of health-wise, and so they do take them for their shots, which I thought was interesting. Fluid hydration is important to keep the mucous membranes and secretions moist. Give oxygen if you need to keep the saturation between 92 and 95%. And then if you're giving oxygen, probably you need to be transporting them as well by ambulance to the emergency room. Excuse me. You can tell them that to humidify the air is good, so they can use vaporizers at the bedside, but just make sure that they, wipe them out daily and definitely bleach them out once a week. Bulb syringes are good for little babies because they're obligatory nose breathers. So if they cannot breathe through their nose, they're not going to be able to suck on their bottles and eat. So tell the mother to put the saline nose drops, couple in each nostril, and then use the bulb syringe to suck out the baby's nose. And a lot of people use nasal rinses and sprays and baby pops. That's what they call it. Antibiotics are one of the medicines, of course, you'll be giving to these children. Analgesics and antipyretics, decongestants, antihistamines, cough medicines should not be given to children under 6. Expectorants, the best is water. Do not use them under 6 years of age. In cough medicine, the only recommended one, and I really seriously do not know where you get this, is buckwheat honey for older than 1 year of age. And of course, you wouldn't want to give honey to a baby under a year of age because there's a chance for botulism. Do not use zinc or vitamin C on these children. And there is some question and study is ongoing about whether probiotics actually have some use in children with respiratory problems. So a long time ago, they used to take everybody's tonsils and adenoids out. It was almost like a rite of passage if you, while you were growing up, that you would lose those inevitably. But now they know and they understand that it is a risky surgery, and so it's not something to be entered into lightly. I have, while I was a nursing student, seen a 7-year-old die after a tonsillectomy and adenoidectomy. The chances for bleeding occur about 1 week to 10 days after surgery, where the clots are dissolving, and that's exactly what was happening with him. And there weren't on the floor what are called tonsil sponges, which are things that look like tongs that you have in your kitchen, and they have cotton on the inside of those, and so you put those in the throat and open them up to compress the size of the throat and stop the hemorrhage. But with this little child, they weren't there, or they weren't even invented at that time, and they couldn't intubate him because of all the bleeding, and so he eventually, in a short period of time, actually died. So what are the indications for tonsillectomy? More than 7 episodes of throat infections in the past year. That's a lot, right? More than 5 episodes of throat infections in the past 2 years, or at least 3 episodes per year for the past 3 years. So those are the criteria for when you would refer for a tonsillectomy, or if you have recurrent peritonsillar abscesses and periodic fever with aphthous ulcers and adenopathy, that may be an indication, as well as obstructive sleep apnea. So you can refer for that. The definition of a throat infection includes a temperature higher than 100.9, cervical adenopathy with tonsillar exudate or positive strep throat. Our antibiotics had to be administered in suspected or proved cases of strep. If the test comes back negative, tests are not infallible. So if the throat looks like a strep throat, the child acts like he has a strep throat, then a lot of people will want to treat. Anyway, I do know that whereas most strep throats do not occur in younger children, there was a baby died several years ago that went to the office, wasn't tested or wasn't treated for strep, and he did eventually die from strep. Indications for adenoidectomy. If the medicine does not treat the adenoid hypertrophy, or if there's recurrent chronic otitis media, even after tube placement, and chronic unresponsive sinus infections. It may also be considered in children with sleep apnea. Now we have now reached the point where the other tape picks up, so I'm going to close here and let Ron combine the 2 tapes for you, or send them out as part 1, part 2. But this part was recorded, so thank you for your patience in getting this back. And I will email you and let you know that I have recorded the first part now, and I'm not sure when they will be combined, how soon. But we at least have both parts recorded now. So thank you for your attention.